Hey everyone, this is Dr. Constantinides, and here, let me stop my screen share for a second so you guys can see me. I'm Dr. Constantinides. Welcome to a Rhinoplasty webinar. We'll be, 20 to 30 minutes. We'll leave some time for questions. With me is Devin Wright. Devin is our cosmetic consultant. Say hi, Devin.
Hello. Thanks for joining us.
Anyway, Devin will come on a little bit later during our Q&A. Now, really important for this webinar is the little Q&A box. If you look at the bottom of your screen, or depending on how you have it set up, there's a Q&A box. And so if you would like to ask a question, please type it there. We are not allowing for, this format doesn't allow for live question, you're asking it in person with your voice, but do type any questions you have, and we'll try to answer all of them at the end of the webinar. Okay, great. So let's get started. And today we're talking about rhinoplasty, and the two things that I want to cover are basically these two questions. Doctor, can you help me look better? And doctor, can you help me breathe better? I'm Minas Constantinides. I'm a facial plastic surgeon. I'm double board certified in otolaryngology, ear, nose, and throat surgery, and facial plastic surgery. A little, let's see, there we go. A little short bio. After College at Brown and medical school at Columbia, I did my residency in New York at NYU in otolaryngology, or head, neck, ear, nose, and throat surgery. Then I did a fellowship in facial plastic surgery in Toronto, and then I was hired back to start the facial plastic surgery department or division in the ENT department at NYU. So I was director of facial plastic surgery as the sort of guy that started the whole thing going at NYU for 20 years. I taught, I did research, I trained 14 fellows, and in those 20 years, I also helped to train 80 residents. So it was a great teaching experience. I had a private practice in New York as well, focused primarily on rhinoplasty and revision rhinoplasty. And then I moved to Austin in 2015, mostly just to improve quality of life and sort of be in a place where I could be a little bit happier in terms of lifestyle, climate, and patient mix. I mean, and it's been a fantastic change for my wife and me uh, here in Austin. I've been on the leadership in facial plastic surgery nationally. I was on the board of directors of the American Academy of Facial Plastic Surgery for 9 years, and then currently still a senior advisor for the American Board of Facial Plastic Surgery. So I know a little bit about what I'm talking about, and hopefully y'all will see that as we get into this talk. So basically, there are two types of rhinoplasty: functional and cosmetic. Now, so what's really the difference between functional and cosmetic rhinoplasty? And the answer is not much, in the sense that with functional rhinoplasty, we want to improve breathing, but also want to improve shape, appearance of the nose. With cosmetic rhinoplasty, there is no underlying breathing problem, but we want to still improve shape. And sometimes it's hard to tell just by looking at people whether they're functional or cosmetic. For example, under this functional slide, here is a deviated nose that's broad, and well, you'd say, well, this looks like a cosmetic problem. Well, she just can't breathe. She has some sinus issues, and so it's a functional problem too. Under the cosmetic nose, well, she's crooked. She may have broken her nose, or maybe that's the way she grew up with it. But she's primarily interested in improving shape and doesn't have a breathing problem. So that's essentially the difference. Goals of rhinoplasty in general are to change the shape of the nose so it no longer draws attention to itself and away from the eyes and the smile. So in my opinion, goals should be that you still look like you. If you want to look like a different person with a tremendously aggressive change, then I'm not your surgeon. I want patients to feel like they look like a better version of themselves. And others around you, when they see you, if they don't see you black and blue and swollen, should not be able to tell that your nose looks different because they're not, although it will look different, they aren't focusing on the nose. They just think you look better primarily because your eyes will look better, your smile look better. And and of course, with functional rhinoplasty, we want to improve breathing, but with cosmetic rhinoplasty, function is really important. I do a ton of revision rhinoplasty surgery, and a lot of the reason for the revision is that the breathing was fine pre-op, and now after surgery, there's new obstruction. So with cosmetic rhinoplasty, we really have to pay attention to make sure that breathing is maintained, and even if there's no problem, we always want to look to see what the traps are in terms of planning the surgery. Where could there become a problem that we don't recognize and try to fix that at the same time. So functional rhinoplasty, here's a before and after, and the differences here that are with we'll talk first about aesthetics. So here on the left side, the preoperative view, we see a straight line drawn between the eyebrows and down to the middle of the upper lip. And so that's a straight vertical line that where the nose is primarily to the right, is, 2/3 of the nose is to the right, to her right of midline. So that's a deviated nose that we want to try to straighten. And we want to try to straighten it so that both the septum, which is the top of the nose, is the top of the septum, is now able to be straightened from top to bottom, but also because a straighter nose draws less attention to itself. We also, here are the, these are the, this is the angulation of her nasal bones before surgery, nasal bones and cartilages of the middle part of the nose. And here, after surgery, straighter lines from top to bottom. And this really helps to highlight the eyes. By taking a deviated nose and making it straighter, now we're looking more at the eyes and more at the lips. Of course, the tip has been improved, and nostril shape in general is better. Profile views, a shorter, more elegant profile that still looks like her. Now, if you look at this and you say, well, gee, that doesn't look like her at all, it looks quite a bit different. But in fact, she still looks like herself. She doesn't look like someone else. It's just a better version of herself. So no one's really looking at a before and after unless you show them your before and after, or if you're looking at before and afters online, say on Instagram. But in real life, no one's looking at a before and after. They're just looking at you. And in her case, she just looks better. And I'll tell you that no one in her life said to her, well, gee, who did your rhinoplasty? Because no one can tell. It's just that she looked better and people can't put their finger on why. Smiles enhanced, of course, by supporting the tip and preventing this droop as she smiles, things look better too. So with functional rhinoplasty and cosmetic rhinoplasty both, I have patients fill out these 2 quality of life surveys. And these surveys are really helpful to identify how bad the problems are for each of these important topics in rhinoplasty. So with breathing, how bad are the various parts of the breathing that we worry about? And then with this survey called the Schnoz survey, how is the breathing, but also how is mood affected by the shape of the nose, and how much of a problem is the appearance for this patient, and in this first scale, anything above 10 in terms of functional problems is a significant quality of life issue. So that's sort of one thing that we look at with this. The second thing this does for us, these surveys, is to help to tell the patient how much improvement they'll have with surgery. So with successful surgery on this scale, a patient will go from, say, will move 2 points, and that's successful surgery. So nasal congestion or stuffiness in this patient, by the way, these are the scales from the patient that I showed previously. This is this patient's actual scales that she rated before surgery. And with successful surgery, it'll be a 2-point move. So if it's a severe problem, still stays as a moderate problem. We don't get to ones or zeros except for extraordinary cases. But the fairly bad problems become very mild, and that gives the patients an indication of how much improvement they can expect. In this scale, because it's a 6-point scale, it's a 2 to 3-point moves. Typically a 3-point move with successful surgery. So again, not zeros with these really severe problems, but ones and twos. So rhinoplasty can only do so much because we have to be able to deal with your own tissues as we move them. And so people think that plastic surgery, well, you can do anything. The truth is that's absolutely not true. We take whatever you give us and then reshape it and form it and support it to create an outcome that is predictable and long lasting. But you will not be able to get an outcome that that is beyond what your own tissues will allow for. And so that's a really important point that we stress in our preoperative visits. Then we do this sort of examination. This is an examination scale where I ask a patient to rate their breathing from 0 to 10, and then they give me an answer, and then I support parts of the nose, and then we see how much change or improvement there is. And this helps me decide with the patient what areas are weak and what areas need additional support so that we can get a durable change. Now, with every rhinoplasty, I go through this sort of drawing. I draw what I do, and then I go after surgery when the cast comes off, I explain with this drawing what I've done for the patient, and they get to take this drawing home. So in this case, this was a functional and cosmetic rhinoplasty, but in addition, I worked with a sinus surgeon who did sinus surgery at the same time because she had pretty severe chronic sinus disease. And so we were able to do all that together, so her nasal shape, but also function, all the way back through her sinuses are improved with the surgery. We try to maximize outcome with these operations for patients. And so, for example, here's a side view, a drawing of the side view of a septum. And in her case, we had to take out we took out some cartilage to use to support the nose in various ways afterwards to make the result long lasting. This was a very deviated septum where I had to do extensive rebuilding of the septum to get it straight and then support the rest of the nose to create an outcome that was really exceptional, as you've seen. Now, so some of the things we did in her rim grafts, cartilage grafts along the rims to prevent nostril retraction so that her nostrils are supported and straighter after the surgery. We did a little bit of excision of the tip cartilage just to help to define this, but most of the tip was changed with suture techniques only, and supporting the bottom of the tip with what's called a septal extension graft, a graft off the edge of the septum to help support the tip in a long-lasting way. And that with all these changes, we get a change that's durable and strong and supportive. So let's now turn to part of the, really important step in the consultation process, I think, is photo imaging. Photo imaging is where we help to figure out with the patient what kind of change the patient wants. And so we'll do this live with the patient. We'll make changes to the shape to her nose and try to have a discussion about what changes would be realistic for her. And she wanted, a straighter top, no bump, a little bit smaller overall, but not a huge change to rotation. And so definition, straighter, but not a huge change to rotation. And this is our after result with her at 3 months. So she's still a little puffy at 3 months, but you can see that improved from pre-op, and then the imaging result and the actual result, correlate pretty well. We try to be as realistic as we can with our imaging. Again, we do 3 views: profile, oblique, and front view with the imaging. And so oblique view, we little, and the changes that we'd like to see, and then her actual change at 3 months, which is coming along really beautifully for her. Front view imaging, that crooked nose I've made straighter with a little bit of tip definition, and here's her actual result. And you see with the imaging, her nose is straighter, but not absolutely straight on the imaging, because we don't want to over-promise, right? I think whatever we can do realistically. But here she has an absolutely straight nose, so we got an even better result in terms of straightening than the imaging can show. And look at how her eyes are enhanced on front view just by making the nose straighter and a little bit more balanced and symmetric. Still looks like herself, just a better version. So here's another patient who wanted cosmetic rhinoplasty, and on front view we see some asymmetries in the bony part of the nose, a little bit of width. She looks a little washed out. Tip is a little asymmetric, deviated, and when she smiles, her tip plunges. On oblique views, we see similar sort of issues. A small amount of height here, more visible on the right side because of the deviation she had than the left, and a little bit of a longer nose, a longer tip, and of course a bump, and the tip not looking a bit long. So one thing we like to do is actually video the on-table results. Before and afters on the table are really helpful for patients, because at a week I can show them these changes, and we can sort of she'll get a sense of what the nose will look like just right after surgery, before all the
Hey guys, up to rhinoplasty today. Bump improved, nasal length shortened, tip definition improved, rotation improved. She should just love it.
So that's before surgery.
Hey guys, up to rhinoplasty today.
And then on table immediately after surgery results. This is that same patient we saw with those pictures before this. So a nicer, straighter line to the top of the nose, a nice transition from top to tip. We did alar base reductions in this case to improve alar width, and there's always a little incision here at the bottom of the columella. But the transition between upper lip and tip is improved too, so it's not quite as plungy, and really pretty overall changes, I think. And then,
all right, here we are at the end of the surgery. Really nice shortening, natural appearance, alar base reductions, make the nose and tip look much narrower, but balanced with her face. All right, here we.
And then one of my favorite times is when we actually get to show the patient once the cast comes off. This is 1 week after surgery on that same patient we've been seeing.
Oh, I'm scared. Whoa. Oh my God, it looks so good from the sides. That's crazy. Wow.
You look amazing.
That's crazy. Thank you.
You're welcome.
I love it. That's crazy. Oh my God. I have a new nose.
Just love that. Now, this patient I'm interviewing a month after her surgery, just to get a sense of what her experience was like with her earlier recovery.
We're a month after surgery.
Yeah.
That's right. And how was the first week of healing?
First week wasn't that bad, honestly. I had like a little pain, but like after medicine I was fine. And it was like swollen, but like I was fine, honestly.
Well, that's awesome. And then how about afterwards? Because you guys went back home to California a week later.
Mm-hmm.
Yeah. How was the flight?
The flight was actually fine. I thought it was gonna be a lot more swollen. I actually did not change breathing at all. I'm not scared about that.
Oh, that's great.
And I went home, taped, went to bed, and I was like just how I was in the office. So
Perfect. That's amazing. And how long did it take for your breathing to feel better than before surgery?
I would say like 2 weeks.
Oh, that's pretty good.
Yeah.
That's
I
great.
started feeling a lot better. Yeah.
Did anything surprise you from what you were expecting?
Surprised me. I think just how easy it was, honestly. I was really expecting it to be like it drained everything out of me, but it was really good and I feel great after. I know some people they say like afterwards they were like, oh, I don't recognize myself, I don't feel great, but I felt great like this whole time, like never had a doubt. So,
That's amazing.
yeah.
Well, you had a beautiful result.
Thank you.
We're only a month out. It's going to keep getting better.
That's great. Thank you.
You're welcome.
So it's important to recognize that at a month, there's still swelling in the tip, and the tip position is actually higher than it will be because of swelling at the base of the nose. And so it takes about 3 months for the tip and shape of the nose to be what it will be at more or less at a year. Nostril shape is different. Nostril shape, there are subtle changes that can occur for up to a year because there's very little structure in the nostril. And even when we add little grafts to create structure there, subtle changes in swelling will change nostril shape. So we don't actually even look at nostril shape for a year because it takes that long for things to settle completely.
We're a month out.
So, common questions. How long does rhinoplasty take? Both functional and cosmetic rhinoplasty. Frankly, there's not much of a difference in how I do that surgery because cosmetic rhinoplasty still requires me to consider where the weaknesses are, and I need cartilage from the septum to support them with grafts that will help to give durable results. So 3 hours of anesthesia for both types of surgery for primary rhinoplasty. What kinds of anesthesia? Everyone's asleep under general anesthesia. There's a breathing tube placed, which helps to protect the airway during the surgery. That's removed before you're awake, but sometimes you'll get a little sore throat in the back of your throat for a day or two, and that's from pressure from the breathing tube. Well, I'm scared to feel pain. Well, you heard from our last patient, pain is not really a big part of the recovery. We give celecoxib, which is also called Celebrex, which is a non-steroidal anti-inflammatory like an ibuprofen that does not cause bleeding. And that helps to control pain. Lots of ice helps to control pain. We prescribe narcotics if patients need them, but after 2 days, it's rare to really need a narcotic, if at all. The worst part of the recovery is that you can't breathe at all through your nose for the first few days, and that you have to breathe through your mouth gets dry. It's really, really uncomfortable. We don't use packing after the nose, after the surgery in the nose, so there's no like real dense congestion, and we try to avoid any stents or anything that could cause additional discomfort. But the worst part's still obstruction. How can I heal faster? We really go through a lot of things at your preoperative visit to help to heal faster from rhinoplasty, including dietary recommendations, products, and how lymphatic massage helps afterwards. And how long do the results last? Well, we really build a nose to try to last a lifetime. And of course, there are age-related changes, but far fewer than without rhinoplasty. So sort of the typical time course, day one is we see you back the day after surgery so we can show you how to take care of your nose and review all your instructions. We'll look at your before and afters that I took on the table too, so you get some sense about how things will look once the cast comes off. Day 7, the cast and stitches are out. If I've used splints on the inside, they're really thin sheets of rubber along the septum. They're not big tubes, and those will come out on day 7 as well. And then we go through all with the drawings, look what I did, any pictures I took from the inside the nose to show the airway and the changes, and then we review if taping is required or not. And most people after the cast comes off can go back to school or work, but they're still a bit bruised. By 2 weeks, most people around you won't notice anything. The bruising all gone, and you can get more active. 1 month, your smile is stiff for a month because your lip won't rise normally, but you can do a full workout by a month, and the submerging in a pool is usually okay at a month. 2 months, you can submerge in a lake. 3 months, 90% healed, although the tip is still stiff and numb. It's the tip position and the shape of the nose is about 90% of where it will be at a year. And then 1 year is what we think of as fully healed. If a touch-up surgery needs to be done, then that can be planned for after a year of healing, because it takes that long for the nose to completely heal. 3% of my patients need a little touch-up procedure, which is usually just a little thing that we do under local in the office, to either because there's some breathing issue that needs to be corrected, or maybe there's a little bump in the nose or something like that. Usually these little touch-ups are just that, just little things. Doing full kind of revision surgery for touch-ups is very, very rare in my practice. So what's next? So you already met Devin beforehand. She'll contact you by email. You can schedule a complimentary consultation with Devin by replying to that email, or you can schedule it with Devin online. And if you want to take a little screenshot of this screen, so you'll have this information, devinw@westlakedermatology.com. But look for her email, and she'll be able to get back to you. You can schedule a paid consultation with me if you want, by either online or calling my office at Lamar Central, which is where I work. Are there any questions that might have come? Now remember, you can still, if you have any questions, please feel free to type those into the Q&A box at the bottom of your screen, and we'll try to answer them all. Devin.
All right, so I have a few questions that came in. First one, as tissues age over time, is it normal to expect sagging or looseness in the tissues of the nose? I am experiencing breathing and minor cosmetic issues after having a rhinoplasty approximately 20 years ago. What techniques do you use that ensure results last a lifetime?
Yeah, that's a great question. So I think I touched on that a little bit, but let's go over that. So every rhinoplasty is done with a septoplasty. Even a purely cosmetic rhinoplasty needs cartilage. I need cartilage to help to support the nose and strengthen it in areas of weakness so that the result is durable for a lifetime. Now, age-related changes are normal. With the nose in particular, changes to the skin occur, just age-related changes to the skin, but also the ligaments that hold the tissues together in youth get weaker and saggy as we get older. And so you can have drooping of the tip, typically, separation of the tip. You can have knuckles sometimes form, or bosse, abnormalities of the tip that create asymmetries. Nostril shape can change. So we try to account for all that in primary rhinoplasty and strengthen the areas that I know will get weaker over time. But if you had a rhinoplasty 20 years ago, then it's very likely you had an older style rhinoplasty. Now, I've been in practice 30 years, and I know the rhinoplasties that I was doing 20 years ago are much different than the rhinoplasties I'm doing today. Because I've learned over the 30 years in practice what kind of changes happen slowly over many years. And so 20 years ago, you may have had a rhinoplasty that was one that used cartilage to support the nose, or you may have had one where things were just moved around and tissue was taken away to create narrowing. The latter creates more chances of weakness over time than the one where there's structural changes. But even with the structural rhinoplasty that I was doing 20 years ago, techniques are different today, so that results, I think, are better in the long term. Hopefully that answered the question.
Perfect. Another question, is touch-up surgery, if needed, included in initial cost, or is it in addition? Does this depend on whether it's a breathing issue or a cosmetic one?
Sure. So if there's a breathing issue that persists after surgery and you have insurance, then I may bill insurance if we need to do a touch-up, if insurance will cover it. Otherwise, there's no cost to touch-ups.
Perfect. Is there a
Uh,
best age?
yeah,
Oh,
just
sure.
with the exception, sorry, when I say no cost, I don't charge anything. But if you need to go to sleep for it because it's something deeper in the nose or something that might cause some bleeding, then the anesthesia team has to get paid. So there may be a small cost, but um, I don't charge anything for touch-ups. If we can get insurance to cover it for you, that's even better.
Perfect. Is there a best age to get a rhinoplasty?
So there is there is a lower limit. In other words, you should not have a rhinoplasty unless you have stopped growing. And so in women, that is typically 15 or 16 or great or older. And in men, it's typically 17 or 18 or older. Now, in terms of best age, um, there really is, once the nose is fully is grown, then it doesn't matter if you're 16 or 26 or 36 or 46. Once you get into your 60s and 70s, the surgery can still be done, and I've done plenty of rhinoplasty in patients 70 and older for age-related changes with the nose, but that the healing is slower. You know, as we get older, healing takes longer. But other than that, uh, as long as it's not being done at too young an age, I think we're okay.
Great. Next question. I had a different doctor tell me that if there wasn't enough cartilage in my nose during surgery, they'd have to take cartilage from my rib. Is this normal practice? If so, is there an extra cost for that?
Great question. So, it's quite rare to need rib cartilage in a primary rhinoplasty. In other words, if you've never had rhinoplasty before and you have your septal cartilage is all there to use, then it's quite unusual not to have enough cartilage to use to complete your rhinoplasty. There are some exceptions. In Asian noses, for example, there's very little cartilage and there's a lot of weakness, so maybe more cartilage is required. So in those cases, we might talk about needing to go to somewhere else for cartilage. And that somewhere else could be ear, because we can take the round part of the ear cartilage out with a little incision in the back, doesn't change the shape of the ear, and it gives me cartilage to use. Or if a lot of strengthening is required, ear isn't that strong, septum maybe not enough, then we might have to go to rib, yes. But that would be a really extraordinary situation and not a typical situation. Rib grafting, I do fairly regularly in revision rhinoplasty. Almost always those cases are also partially covered by insurance because in my opinion, and this is me, I don't think it's necessarily man dogma, but for me, if I'm taking rib, I want to be in a hospital setting. So it's very costly to be in a hospital setting if you're paying for it on your own. So for rib grafting, usually, hopefully, insurance will help cover that because the hospital fees are very high when we do rib grafting. Now, why do I want to be in a hospital for rib? Well, I want to be safe. And right underneath the rib is the lung. And if we were going to go a little bit deep with our removal of the rib cartilage, then we could end up causing the lung to collapse. That's called a pneumothorax. We'd have to put a tube in to re-expand it. You'd have to be in the hospital for a few days. Now, I'm going to knock wood. I've never had that happen in my practice. I've probably done between 500 and 700 rib grafts. We've never had a lung collapse, but I'm still a pretty conservative guy. I want to be safe for my patients, so I still like to do that in the hospital setting so I can take a chest x-ray at the end, make sure that everything's normal.
Perfect. So kind of bridging off of that question, another one came in asking if you can use donor cartilage and are the costs and risks the same or different?
Yeah, so there's a lot of sort of discussion in the surgical literature regarding donor cartilage versus your own cartilage for in terms of rib. So donor cartilage that is referring to rib cartilage that it comes from someone who's donated their cartilage or their body to medicine, and so donor cartilage, the results are a little bit mixed in the studies whether it's better or worse than your own cartilage. To me, it kind of makes sense that if I could use your own stuff, then I'd rather do that than have to use donor cartilage, someone else's stuff, because I have greater confidence that your own stuff will last a lifetime. Now, having said that, rib calcifies as we get older. So, for me, if someone is 50 years old or less and I need rib, I want to use your rib. Rib cartilage, the recovery is actually remarkably easy. It's not super easy. You can't do a sit-up for a month, but it's not that uncomfortable to have a rib cartilage harvested from yourself. And I but if you're older than 50, I don't want to risk that it's calcified partially. Calcified will make it harder to use and harder for it to do what I want it to do. So in those cases, I use donor cartilage. And donor cartilage, yes, there's a cost to it, and but it's a nice product in the right situation when we don't have other options.
Perfect. Can you combine a rhinoplasty with other procedures such as a chin implant or neck lipo?
Uh, Absolutely. It's quite common to combine rhinoplasty with chin augmentation. Really important to do photo imaging because once we change the nose, the chin may no longer be as big an issue. I've had patients with quite small chins where they and I have thought their chin implant would be helpful, but once I image it, it doesn't look right. It's not the change that they wanted. And so photo imaging really, really essential in my opinion for both chin implants and rhinoplasty. They can be done together in the right patient. Neck lipo can also be done at the same time as rhinoplasty. There's no issue at all.
Perfect. And then if I have a big event coming up, when should I plan my rhinoplasty?
So I guess it depends on the event. If you're getting married, then I would say, you'd want to give a really good amount of time to heal well, to make sure that everything is settled, and to make sure that if there's any little thing, it can be touched up. So ideally, I mean, I would say no closer to your wedding than 6 months, and that's, pretty close. I mean, I would vote for a year if you could, but 6 months. Now, if it's say you're in a wedding but not getting married, then if you're part of the wedding party, you want to give a good amount of healing time so that you can take pictures and not worry about things and that sort of thing. I would say 3 months is a good idea, is a good length of time to wait. And if you're just sort of giving a big lecture, presenting at something in your company, and you want to look better for that, usually 2 months is sufficient for that.
Perfect. I did get one question about the cost of the rhinoplasty. I'm happy to answer that if you'd like. But if there is anyone that's wanting a specific price quote, just reply to the email that I send you. I just have to go through a couple questions and then I can send you a specific price over tailored to you.
Yeah, I think just replying to Devin's email is the best way to get a cost estimate for all this.
All right, and I think that's all, unless anyone has any last minute questions they would like to submit.
Yay. Well, thank you very much. And I have one more slide to share. Hold on, wait for it. I lost there we go. This is from our recent meeting in Los Angeles with reconnecting with old friends and Paul Nassif and I go back probably 15 years. We're very good friends, and I really enjoyed seeing him when we were together at our national meeting last week. So hopefully everyone knows who Paul has made his name as the botched rhinoplasty surgeon. He's
Love it.
all right, guys. Thank you very much, and I appreciate everyone coming on, and hopefully it's been helpful for y'all.